Good afternoon and welcome to today's presentation, Toxicology 101 for Attorneys. In today's webinar, Dr. Muller will discuss the expected effects on the body from common street and prescription drugs, the difference between drug and alcohol levels obtained from blood, urine, and breath, common false negatives when interpreting drug screen results, the utility of drug levels for commonly encountered street and legal drugs, and the correlation between drug and alcohol levels and the level of impairment. To give you a little background about our presenter, Dr. Allison Muller, she is a healthcare leader with more than 20 years of experience in healthcare program development, medical communications, professional education, and clinical toxicology. She is a board-certified clinical toxicologist that provides expert witness testimony for cases involving alcohol or drug-related vehicle accidents, carbon monoxide exposure, environmental issues, medication errors, poisonings, and pharmaceutical product liability. Attendees who require a passcode, the word for today is toxic. During the Q&A session, we will ask you to enter this passcode into the Q&A widget for CLE reporting purposes. The Q&A is located to the left of your screen. Please remember that if you are applying for CLE credit, you must log onto your computer as yourself and stay for the full 60 minutes. You are also required to complete the survey at the end of the program. Please note that CLE credit cannot be given to those watching together on a single computer. Tomorrow morning, we will send out an email with a link to the archive recording of the webinar. The slides can be downloaded from the resource list to the left of your screen. Thank you all for attending today, and Dr. Muller, the presentation is now turned over to you.
Thank you very much, Emily, and thank you for having me do this webinar today. So I also really like the passcode for today, keeping with today's theme of toxicology. So as Emily said, I'm a clinical toxicologist, and I have over 20 years experience in the field. I'm also a registered pharmacist, which is what I originally went to school for. So I've done many talks in toxicology for physicians, and I'm doing more of them for attorneys, really identifying what kind of questions attorneys need answers to when they come to me as a toxicologist, to understand if their case is a viable one, to really understand at a high level what these drug levels are, these alcohol levels are, and how they can really get an understanding with just an hour talk of the basics of toxicology. So we'll start with some definitions just to get a lay of the land in toxicology. First, we'll start with a metabolite. So after a drug starts to break down in the body, it breaks down into active and inactive products known as metabolites. Now, some of these metabolites may be even more potent than the actual original drug, or they may be inactive. And I mention metabolites because you will see them mentioned when you're looking at certain laboratory reports that are measuring drug levels. Not all drug levels are actually the parent drug. They may be measuring the breakdown products of a drug known as metabolites. Now, metabolism occurs in the liver, and metabolism of a given drug is going to vary person by person, meaning how quickly a person is going to break down a drug into metabolites. It depends on things like genetic factors, what their liver function is, and what other drugs they take on a regular basis. The next definition is detection time. And detection time is everybody's question in terms of, okay, if somebody used a drug at this date, for how long will they still come up positive, or how long will the drug still be measurable on a toxicology screen? And the detection time is going to vary from drug to drug, of course, but it's also going to vary with the amount of drug used, and very key factor is how frequently the person uses that particular drug. In general, 30 days is usually the window for time past last use of a drug where you won't be able to detect it. So if somebody used the drug on day 1, at day 31, if they haven't used it within that time period again, they're not going to trip a toxicology screen for that particular drug. And finally, route of administration is just simply how a drug gets into the body. So the oral route is by mouth, and when a drug is taken by mouth, it goes to the liver to be metabolized before it reaches the bloodstream. Now that's key because the drug becomes broken down by the liver and then has the effect of forming the metabolites and the patient's individual characteristics of how they will metabolize that particular drug. But some drugs are actually inactivated when they are taken orally. So for instance, something like insulin is completely inactivated if it's given by mouth. That's why it has to be given via injection. Other routes of administration that will bypass the liver, intravenous routes, intramuscular, and intranasal, for example. I took several semesters of a topic called pharmacokinetics during my undergraduate and graduate programs, but I can whittle it down to 4 major areas that would be of interest for you in terms of understanding some of the things that you will come across in toxicology reports and in drug and alcohol impairment cases. So pharmacokinetics is defined as what the body does to a drug. So the first thing is absorption. So this is the time it's going to take for a drug or alcohol, and alcohol itself is a drug actually, so the time it takes for a drug to be absorbed into the bloodstream, and that's going to vary by route of administration and with the amount of that particular drug. Now some things can affect absorption. One of the things, let's say in the case of alcohol, is having food in the stomach. That certainly slows the rate of alcohol absorption from the stomach into the bloodstream. So in general, with the example of alcohol, peak alcohol levels are reached within about 30 to 60 minutes after the last drink is consumed, but food can delay that somewhat. I mean, not hours later, but 15 minutes, 30 minutes later. And it can affect the peak concentration of alcohol. It can result in a lower peak concentration, meaning the highest level of alcohol, and it would give it a longer time to be at that level versus an empty stomach. The third pharmacokinetic principle is metabolism. We talked about that previously in terms of what a parent drug is. That's the original drug. And then the metabolites are what's broken down, the pieces broken down of the original drug by the liver. And it's one of the very first steps for eliminating a drug from the body. And the final pharmacokinetic principle is elimination. And we'll cover that on the next slide. And I want to talk a little bit about alcohol and elimination on this slide. So elimination of a drug from the body usually involves a couple pathways. So we talked about the first pathway, and that's metabolism via the liver. And then elimination is also via the kidneys, and that's excretion. And so I want to just go over this graph briefly. This is a time versus concentration graph showing 2 types of kinetics. And I will try to keep this as simplistic as possible, but I think it's an important point to understand, especially when you're trying to determine levels of drugs or alcohol retrospectively. So alcohol is eliminated via a zero-order kinetic pathway. So in other words, if alcohol undergoes zero-order kinetics, otherwise known as fixed-rate kinetics, that means that regardless of the amount of alcohol in the body, the rate the alcohol is being metabolized is going to be unchanged. So more alcohol or higher levels of alcohol doesn't mean that the process of getting the alcohol eliminated from the body is going to be sped up. So hence you see the straight line of the time versus concentration graph. So if you have a straight line, if you have one point in time with the concentration, you can go backwards and pretty much pinpoint, at least maybe not an exact one, but pretty darn close, of a time prior to the level that you have and see what the concentration was. Now, this is very different than drugs, and most drugs undergo first-order kinetics, and you can see that's a curve. Now, most drugs, I say, undergo first-order kinetics. Some in overdose will switch to zero-order kinetics, but for sake of what we're looking at here in terms of how to find drug levels retrospectively, what I want to demonstrate to you is that how would you go back in time and see what a drug level was retrospectively? So if you have one point in time and it's a curve, it's a drug eliminated via first-order kinetics, it's really not an accurate science to go back and find out what the level was an hour prior to that level you have measured, or 2 hours prior, because you're working with a curve there. So that's really the take-home point about pharmacokinetics and the different orders of elimination. So we went over pharmacokinetics, and that's what the body does to the drug. Now we have pharmacodynamics, which is what the drug does to the body. So there's many over-the-counter, illicit, prescription drugs that can certainly affect a person's driving ability, for example. And when you're looking at pharmacodynamic data, meaning what the drug does to the body, we don't have that necessarily on every drug. I mean, not every drug has been fully studied in relation to what exactly it does in terms of its potential to cause impairment. So drug impairment requires an understanding of some of the unique properties of certain drugs and how they exactly impair driving. Most of our information is on alcohol. We have a lot of good information in the scientific literature on how alcohol impairs driving. And even with alcohol, explaining complexities to a jury, to the lay public about these type of reactions can be challenging, since there's really not a one-size-fits-all explanation in terms of how everybody is going to react and how everybody's impairment will be if using a particular drug. So when I get this type of question, this particular person was found to have this level of a drug, and this was, their behavior at the scene of the accident. I ask other questions too, like, what other medications are they taking? And I want to know everything, like over-the-counter things, drugs you don't need with a prescription, herbal medications, of course, prescription, recreational drugs, how long the person has been taking the drug in question, because there's certainly some tolerance to many drugs, what medical conditions the person has. Some medical conditions can not only affect the person's reaction and level of impairment to certain drugs, but can affect the levels as well. And what exactly was detected in the toxicology screen. I always want to look at the report and see exactly what was picked up on the toxicology screen and what assays were performed and that sort of thing. The other thing that I want to know when I am looking for drug levels, or attorneys will call me and ask me a question regarding a drug level that they found on a medical record and how they can apply it to their particular case. And this happens a lot of times with medical students and pharmacy students that I work with too. They'll give me a level, but they won't tell me the units. And so, we cannot assume that all laboratories are reporting their drug levels with the same units. And, some laboratories will provide, quote unquote, normal ranges. Now, what these normal ranges mean in relation to impairment varies widely. So I kind of ignore when I see the normal ranges on laboratory reports. So when you have drug levels, make sure you have the units, and that should be on the toxicology report. And keep in mind that the predictive value of drug levels related to impairment is quite limited. Another thing that you may or may not hear or read on these toxicology reports is within normal limits. And so I'll have medical students, I'll ask them what the drug level was or what this particular level was of something in the body, and they'll say, WNL. So what is that supposed to mean? To me, it means we never looked, rather than within normal limits, because it's really important to have units. So there's different body fluids that can be used for toxicology testing, and there's also the latest is hair testing. The most accurate of these, the urine, blood, hair, breath, saliva, is certainly blood. A blood sample has a shorter detection time than urine when you're looking for drugs, and it's certainly more likely to indicate recent use versus a urine sample. An advantage of the blood sample over the urine sample, it's much less likely that there's going to be an adulterated sample of blood just because of the method of collection versus a urine sample. But the urine has a longer detection time for many drugs, as well as their metabolites. Urine drug levels don't tell a lot on their own usually, other than that particular drug was used at some time. So it's very hard to tie a level of impairment with a urine drug screen. Those are just like the quick screens to test for drugs of abuse, things like amphetamines or barbiturates, cocaine, opioids. There's usually about 6 or 8 of them. Then there's hair screens. Now, hair samples can detect a particular drug use usually as far as 3 months prior to the testing. There's a much longer detection time since drugs remain in hair and are not metabolized during the life of the hair. I mean, you can't shampoo out metabolites. I mean, you can cut out the hair, but the downside of hair samples is that there certainly can be surface contamination, and I've heard of that before. You know, I wasn't using cocaine. I was around someone that was using cocaine, so that's why you're detecting it in my hair. So hair samples are more to confirm use rather than actually getting a level that you could do something with. You know, I had a question recently about a hair sample and a particular drug of abuse, and you know, the big question was, we have this level, we want to know if this person was impaired because they had this, you know, quote unquote very high level, because again, they looked at the laboratory report, and the laboratory report gave them a, you know, within normal or normal range, and it was, you know, way past the normal range. But unfortunately, with that level, we still couldn't say, well, this is how I would expect the person to be acting or behaving, or, you know, if I would expect them to be impaired, or what this really means in terms of amount or frequency of use. So all that result from the hair testing told me was that they used that drug at some point in time, maybe in the past 3 months, maybe it could have been yesterday, maybe it was, you know, 3 months ago, hard to say, and it doesn't tell me how it would have affected their cognition at all. Excuse me. Saliva. We really have very limited data on drug levels regarding that you find in saliva. That's really an emerging area in terms of having data on cutoff levels, and the testing is still being refined. There's confirmatory tests. So I mentioned the urine drug screen. You know, it's just a quick test, and there's definitely some limitations to the urine drug screen. Really what the urine drug screen is used for in medicine, you know, if a patient is in the emergency department and they want to know if there's any drugs of abuse on board in that patient, they do that urine drug screen. And then if the patient comes up positive for any of the drugs on that screen, they'll do what's known as a confirmatory test. And the confirmatory test is, you might see GCMS, which is gas chromatography, mass spectrophotometry, all I have to know is GCMS, and that's really the gold standard for confirmatory testing, and there's not going to be any false positives on that. There's certainly false positives on urine drug screens, there's false negatives on urine drug screens, and I'll talk about a bit more about what those are and when you see that. But gas chromatography separates the drug, and then it goes into the mass spectrometer and has the molecular fingerprint, so to speak, of the drug, so there's no false positives. I will tell you, though, if there's a positive result for cocaine on a urine drug screen, I have never heard of a false positive for cocaine, even on a urine drug screen. So there's many different drugs out there that could cause impairment, and they're not all, drugs of abuse. They could be valid prescription drugs or over-the-counter drugs, that are not required to have a prescription. So all those can potentially impair a person's driving ability. But again, the take-home point is that there may not be scientific information to connect the drug level that you have to how that particular person would be expected to act. So, as the example, even with the hair testing, drug levels, even with blood levels, are not always useful in pinpointing when a drug was used, what dose was taken, or what the expected effect on that particular person could be. So one thing I want to make sure that I highlight is that you should know that sometimes we as experts can make a very educated, scientific guess, so to speak, to those, kind of unanswered questions about the drug level and how it relates to the person's behavior and level of impairment, if we have some other information. So things like, how much the person weighs, what their medical history is, and information from bystanders at the time of the incident, how long the patient's been taking the drug, and, if there's also alcohol along with that drug, so some interesting things. So a question that I had recently was regarding an alcohol level in a gentleman. It was, like 0.14. So 0.14 sounds like you would think that that particular person working at the bar that night would find that person to be intoxicated. Shouldn't serve him anymore. Don't you think he would be stumbling or slurring his words or, acting outright intoxicated? And my answer was, no, not necessarily. 0.14 sounds high, the legal limit being 0.08. But if this is somebody who uses alcohol on a regular basis, they could look stone cold sober to the person working at the bar that night, even with an alcohol level higher than the 0.14. So there's other things that go into it besides just a level with drugs and alcohol. So I've told you a lot of limitations of drug levels. So let's just drill down what really a positive result for a drug can tell you. Well, it tells you that in some point in time, the patient used the drug maybe. I say maybe because there definitely are false positives. And then if there's no confirmatory test, then you're left wondering, did this drug screen, really show a true use of this drug or not? And then again, there may or may not be information to tie a drug level to how a patient would be expected to act. That those type of information are really starting to emerge. We have much more information on alcohol in that regard. So again, what can drug levels not tell you? You can tell these are important points because I brought these up earlier as well. They can't pinpoint when the drug was used or the dose. Remember that time versus concentration curve about the first order elimination of drugs. You have the drug level at a certain time after an incident, and you want to go back to an earlier time. That's not going to be very precise to try and figure that out. Sometimes we can make an educated guess based on, some signs and symptoms at the time you're looking to, figure out if the person was intoxicated, but the level that you got down the road was not going to be too helpful at all. So I will pause a moment to see if we have any questions that came in so far. Okay, I see.
And could all the attendees get the passcode into the Q&A? And I see some people are having some audio issues, so if you can hear us, please let us know.
So I have one question I see that came in here. Can patients with diabetes have a falsely elevated blood alcohol level? And that's an interesting question. I could tell that you're thinking along the lines of, okay, medical conditions, you want to know these things, so how can they affect levels? So the answer to that question is no. So patients with diabetes cannot have a falsely elevated blood alcohol level. Possibly somebody with diabetes that is not being managed well can have elevated breath alcohol levels because there's some breathalyzers that pick up one of the byproducts of somebody who has diabetes that's not very well controlled, known as acetone, and they'll sometimes pick that up as alcohol. But a blood alcohol level will not be falsely elevated in that patient. Another question that came in, what is the concept of rising alcohol levels? So think of when we mentioned the part about if somebody is drinking on a full stomach. So they will have a delayed peak absorption time. So, typically 30 to 60 minutes is when you get your peak alcohol level after your last drink. But if you have food on board or if you're taking medications for stomach ailments, it may slow your emptying of your stomach and also the absorption of the alcohol from the stomach. So you still may be in the phase where you're still absorbing, hence your alcohol level is still rising. And the only way you can tell if you're at that point or your client is at that point of the alcohol level still rising is you need at least 2 levels. You can't just have 1 level and say, okay, this has got to be the peak. We don't know if it's the peak unless we had 2 levels to see if it's going in the direction of up or not. What does within therapeutic limits mean as to impairment when using a sleep drug like Ambien? Oh, I really like this question because someone's using the terminology within normal limits. Absolutely nothing is what that means, because within normal limits is something that I tend to ignore when I'm looking at laboratory reports in toxicology, because it does not correlate at all to a level of impairment. And it's not like they're doing levels even from a medical standpoint. Somebody who's on Ambien, there's not a level that we're looking at like, oh, okay, they're getting the full benefit from using Ambien because they're within normal limits. There's some drugs that you're actually monitoring drug levels for to make sure that a patient is within normal limits, both for safety and efficacy reasons, but definitely not Ambien. Oh, this is a really good question. This is a really interesting question in terms of forensics, and I've definitely done some post-mortem work. This is a question about post-mortem blood draws, and is blood alcohol tested the same way from a living person, and does the toxicologist have to account for some post-mortem influences, femoral versus heart draws? The simplest answer to that question is it depends what fluid they actually drew the alcohol levels from. It might be femoral, it might be heart, it might be serum, it might be whole blood, it might be vitreal humor fluid. I mean, it depends what the autopsy report has. So then, depending on what fluid the autopsy report is using for alcohol levels, then you have to see what the time is after the patient expired when they actually got the levels. And there's definitely some changes that you need to take into account post-mortem in terms of how the level is either rising or falling. It might be falsely elevated, it might be falsely declined. And I'll take this last question, and then we'll move on to slides. We'll have time for questions at the end, too. So we have a question that came in about an article that they saw regarding the inability to determine a dose-response relationship for cannabis, and is that still the case? That is the case. I think what you're asking is if you have a level of THC, which is the active metabolite for marijuana, that's what we measure for in toxicology, can you then tie that to a dose of marijuana? And the answer is no. And you also cannot tie that to what their level of impairment would be. So if you have a particular level of THC, that does not necessarily mean the patient was impaired or not impaired, because there's not hard and fast rules on, okay, this level corresponds to this level of impairment like we have with alcohol. With the problem with cannabis is that the metabolite tends to get stored in your fat, and everybody releases it from their fat stores at different rates. So it might look like the patient has a sky-high level of THC, but they haven't used it in a week and a half. Or maybe they used it an hour ago. There's no way to know that. So these are all really great questions. All right, so moving on to a little bit more about alcohol. Now, I mentioned the person that, uses alcohol on a regular basis, so we would consider them a chronic user of alcohol as opposed to someone who is an occasional user. And behavior and impairment is going to vary from person to person for that reason, in terms of how often they use alcohol. But also it's going to vary, based on their body weight. Are they male or female? Because women tend to have more body fat and less water than men, and vice versa. Medications or drugs are not going to change the blood alcohol level, but what it can do with medications mixed with alcohol can make the person have further impairment when performing certain tasks like driving. And there are studies being performed to test the effects of certain, medications on, the particular level of impairment that somebody would have with different blood alcohol levels. And blood alcohol levels are very accurate. Now, when I say blood alcohol levels, I look to see if it's a serum level or a whole blood level. And depending on the laboratory, they may or may not be using the whole blood or the serum. The serum level for alcohol may be a little bit higher than whole blood level, so take that into account too. So let's start with false negatives. So when I talk about false negatives and false positives, I'm referring to results of, the quick urine drug test. And the top 3 false negatives are benzodiazepines. So benzodiazepines include things like Valium or Xanax or Ativan. So these are all prescription anti-anxiety or tranquilizers or sleep aids, that sort of thing. Opiates, things like heroin and morphine and codeine, and amphetamines. So it might be something like ecstasy, or it might be something like Ritalin, methamphetamine. So why are these missed on drug screens? Well, because drug screens are picking up for certain metabolites, right? So we talk about what metabolites are and their importance in drug screens. So if the drug screen is picking up only certain metabolites, well, not every drug, let's say in these categories, forms those very same metabolites. So it'll pick up some benzodiazepines and it'll, trip a positive result, but not other benzodiazepines, so you'll get a false negative, which is good news for some patients. Same thing with opiates. Ones that are synthetic opiates or synthetic opioids are often not detected. And when I say synthetic opioids, so, when we think opiates, it's ones that are the drugs that are derived from the poppy plant, so things like morphine. So that's going to be picked up on a urine drug screen without a problem. But then there's drugs like oxycodone, which are synthetic, and those are often not detected unless the test is specifically looking for that. And so again, when I get questions about toxicology lab results, I'd like to see the actual toxicology report, because there's not a one-size-fits-all approach to doing drug screens. And, I'll have to look at exactly what the limitations are of the drug screen, not only the cutoff value for the drug screen, meaning the lowest detectable amount of that metabolite or drug that can be picked up, but what it can pick up and what it can't pick up, because it has to see what we're looking for. The case that I had just reviewed had stated that a patient was not taking his pain medications. He was prescribed oxycodone, but he was not compliant. He was not taking them. And I asked, well, how do we know that he was not taking his pain medications? Is this by patient report? Or, oh, no, because his toxicology screen was negative for opiates. Again, that doesn't necessarily mean it. You can certainly get negative results, and the patient is actually using the drug. Then there's false positives. These are even more interesting than false negatives. So some tests are going to show false positives because they pick up what we call structural analogs, and even drugs that aren't even part of that particular drug class that we're looking for. So things like with amphetamines, things that give you false positives for amphetamines on these drug screens. Again, it's depending on the test used, but some cold medications, like probably the decongestant that I've been taking all day today for this cold, would give me a false positive for amphetamines, or some antidepressants, some stomach medications like things like Zantac, which is ranitidine, false positives for morphine or codeine. Those cross-react with other opioids. I got a question at one of my recent talks about this, about poppy seed bagels. That really shows people are paying attention to pharmacology, I have to say, because morphine is from the poppy plant, and poppy seeds are from the poppy plant. So, eating that poppy seed bagel this morning, is that going to give you a false positive for morphine, for an opiate? Well, not just one bagel, but certainly if you ate, 60 of them. I don't know what the exact exact number is, but you'd have to eat quite a bit of poppy seeds to trip that drug screen. They all have, a minimal detectable amount. And then finally, phencyclidine goes by some other names, angel dust, PCP. There's a lot of false positives for PCP. Things like dextromethorphan, so the over-the-counter cough suppressant in Robitussin DM, for example. Even ibuprofen, depending on the screen, can show up with a false positive on phencyclidine. So the take-home message with this is there's some, drugs that people are taking just, over-the-counter. They're not using recreational drugs, but they can come up with some pretty potent-looking drug screen results that are truly not the case. So then what do we do with these results? Well, hopefully we have some other information in the medical records in terms of a confirmatory test that then can show what the true results are, because a confirmatory test is the end of the story. That'll tell us if it's a true positive or not. So to go over some of the major drug classes, just so you have an idea of what these drugs are, what do these classes mean, what are some examples of drugs in these classes, what did they do to the patient or to the clients when they're driving, how do they affect the driving ability, and what do levels of these drugs do for us, how do they help us interpret a situation or case. So benzodiazepines, again, are things like Valium or Xanax or Ativan, and they decrease someone's alertness and reaction time. They're supposed to slow the nervous system down. That's what they're used for medically. They're to, help patients sleep. They're for, anti-anxiety, they're for anti-seizure medications. So they're trying to slow down the nervous system, not something you want to be taking when driving. So they, of course, decrease the alertness and reaction time. They might cause, of course, some drowsiness. They may cause some amnesia even. Some of them are used intravenously prior to surgical procedures for that very benefit of amnesia, for example. Now, what about the patient that's taking benzodiazepines chronically? You can't say, you can never drive again. Well, they have those pharmacy labels on the side of the bottles for a reason to, warn people that this could impair driving ability, could cause drowsiness. And, patients have to know, it's their responsibility to know that it can affect their driving, and that before they go behind the wheel, they need to make sure that they know how they handle this particular drug. And sometimes, especially in the case when these drugs are used for sleep, they should know if they're getting up the next morning and they still feel groggy from the drug, it's not a good idea to be driving because of the issue with decreased alertness and reaction time. And they do, of course, interact with alcohol. It's just simply an additive effect. They depress reaction time, they cause drowsiness, alcohol does the same thing, and it's an additive effect. They are sometimes detectable on a toxicology screen, and there's definitely some false negatives on toxicology screens, as I mentioned, because of the different metabolites that they all form, and the particular metabolite that a drug screen is looking for is not formed by all of them. And are levels of benzodiazepines useful for us? Can it be tied to level of impairment? The answer is no. You're going to find that's a very common answer when we go over our levels useful. They're nice to know. It kind of confirms if the patient's using the drug or not, but it doesn't really tell us a lot other than that. So opiates, mentioned those things like morphine and codeine and heroin, and you're hearing more and more about opiates in the news these days. I just want to highlight, in case anybody's picked up on this, I'm going to interchangeably use opiates and opioids. They do the same thing, it's just that the opioids are synthetic and opiates are from the poppy plant. So they're used for pain relief, of course, for cough suppression, and there's a huge drug abuse problem in this country right now with this particular class of drugs, and you'll hear a lot about naloxone community programs, which is the antidote for opioid poisoning. It reverses the effect that it has on the body in terms of decreasing the central nervous system and also depressing how the person's breathing. Now, there's really inconsistent evidence, even though I just told you that it affects these affect the central nervous system and they cause drowsiness and they could decrease alertness and reaction time. When you go to the scientific literature, there's really inconsistent evidence as to whether they actually give you psychomotor impairment or not. It really is attributed to factors like the type of opioid that the patient was using, the route of administration, how much tolerance they have. So we'll see different things about that. They sometimes are detectable on a tox screen. Again, there's false negatives and positives for this class of drugs as well. Sometimes the toxicology screen is only going to pick up morphine and its derivatives, and that's it. There's definitely some false positives for opiates. Even one particular class of antibiotics can give a false positive on some of these tox screens. And are levels of opiates useful to us? No, they are not. Antidepressants, there's many classes of antidepressants, and there are many classes because they all affect transmitters in the brain. There's many different transmitters in the brain, and they all affect them in different ways and different pathways, and it depends on the particular type of antidepressant. So, for example, something like Prozac, which affects serotonin, has a low potential to impair motor performance. But patients are still warned because, it's different, from patient to patient, to have caution when operating hazardous machinery or driving. They have to know how they react to the drug before they get behind the wheel. Patients who are taking drugs like Prozac, so those selective serotonin reuptake inhibitors known as SSRIs, so Prozac and Paxil, for example, they shouldn't be avoiding alcohol. And the big reason, too, is it can increase the psychomotor impairment. So alcohol and selective serotonin reuptake inhibitors like Prozac do not mix in terms of having safe driving. They're sometimes detectable on a drug screen, but the levels are definitely not useful, and there's certainly lots of false positives that result from antidepressants. And the levels of antidepressants are not useful for our purposes. Sometimes psychiatrists will measure levels of antidepressants to see if a patient on a particular antidepressant is in a therapeutic range, meaning, okay, we think it should be working because it's within this range. Do we keep going with it kind of thing? But for our purposes, for impairment assessment, it is not. So then we're up to stimulants. So the classic stimulant is cocaine. And there's also amphetamines and methamphetamines, and so it's things that speed everything up. And they certainly result in a change in perception and your motor function, and they cause sensory disturbances and some dizziness and restlessness. Everything is sped up. And you would think, well, maybe that would kind of, help someone's driving. Well, the change in perception is not a positive one, and the sensory disturbances certainly don't make the driving safe. There's definitely inconsistent results regarding stimulants and performance impairment. And really, some amphetamines and some doses of amphetamines can actually enhance performance in some psychomotor tasks, but still not considered safe to be using while driving. And, mixing with alcohol, with one particular amphetamine, methylphenidate, which is a prescription drug for attention deficit disorder, for example, gets into the bloodstream faster when they drink alcohol along with it. And they are detectable on a toxicology screen, although the toxicology screen that's looking for amphetamines can be very specific. So it may not pick up things like ecstasy, which is an amphetamine, but it may not actually pick that up. So there's various prescription muscle relaxants and things like Flexeril or Soma or Zanaflex, and they relax the muscles, which, to sum it up, so relax muscle tone, and some of them can be very sedating, especially Flexeril, and they can really decrease alertness, some more than others. Muscle relaxants like Flexeril can even show up for false positives for antidepressant use, depending on the toxicology kit. And alcohol definitely intensifies the drowsiness and decreases the alertness even further that's associated with these drugs. The levels of these drugs are not useful, and they're typically not even done. So you probably will not come across levels for the different muscle relaxants. But if there's a muscle relaxant on board and combined with alcohol, that could explain impairment even with a alcohol level that's within the legal limits. So cold medications is a pretty broad category and includes things, decongestants like pseudoephedrine, which is Sudafed, the old Sudafed anyway, and then the newer Sudafed, the phenylephrine, and there's many antihistamines and cough suppressants like dextromethorphan, used for the common cold, used for allergies. And we know what they do from experience since they're so widely used. But really anything that can make you drowsy can potentially be enhanced by alcohol. So taking something like an antihistamine, such as Benadryl, and then having alcoholic beverages on top of that is going to make someone more drowsy and affect their ability to drive versus not having that Benadryl with the alcoholic beverages. And some of these cold medications can show up as false positives for amphetamines, like I mentioned, the decongestants. Some of them can do that, and even some antihistamines like brompheniramine. And are levels useful? No. So still no on that. Excuse me. So the basics of some common illegal drugs. My top three would be marijuana, which is the active metabolite is THC. That's what we're measuring for, otherwise known as cannabis. That's generally the most common drug detected in accident-involved drivers. And the effects of THC on driving, you definitely have some altered perception with that and possibly some visual disturbances. There's an effect on reaction time. There might be some sedation mixed in with that euphoria. And if you get a urine drug screen for THC, you're going to pick that up several days following even a one-time exposure or weeks after someone who's chronically using THC. So urine and blood levels do not correlate with the level of intoxication or the level of impairment with THC. Like I mentioned, someone could have a sky-high level of THC. All that tells us is that they used marijuana at some point in time. I don't know if it was yesterday or it was 2 weeks ago. We can't really tell that at all. Cocaine, again, cocaine is one of the classic stimulants. The effects of cocaine look just like an amphetamine. Cocaine metabolite can easily be detected in urine for 2-3 days following last use and for weeks following the last use in chronic users. And, when I get questions about false positives for cocaine, I said, well, there's a first time for everything, but extremely unlikely. Sometimes with hair testing, like I mentioned, the person using cocaine, I was around somebody, smoking crack and must have gotten in my hair or whatever. That's a possibility, because sometimes with hair testing, there could be the external contaminants, but we follow that up with the confirmatory testing rather than reliance on hair testing. There's inconsistent evidence regarding cocaine and performance. Excuse me. Heroin is an opioid, and it slows everything down. That's what opiates do. They slow everything down. They slow the nervous system down. They slow the gastrointestinal tract down. They just slow everything down. And we would expect heroin to be picked up on a toxicology screen without a problem. So I'm just going to go over some, just a couple cases that I had. I just took, a line or two from the case and just wanted to make some take-home points from these cases. So this is a 52-year-old gentleman who was injured while at his place of work, and they did initial drug testing on him following his injury at work, and they got a positive drug screen for THC. And the cutoff value is 50 nanograms per ml. And so THC, again, is the active metabolite for marijuana. And what does a cutoff value mean? So cutoff value means if he was below 50, he wouldn't have tripped the screen and been positive. But because he was somewhere above 50 nanograms per ml, he was positive. Okay, so that was the initial testing. That was just screening him. When they did the confirmatory testing, the blood test with mass spectrophotometry, now we have an actual number, and look, we have units too, of 204 nanograms per ml, and the cutoff is 15 nanograms per ml. Now, how this was presented to me was, I have a client that has this level, and he's, almost 20 times higher than the normal level. So again, that's not what the cutoff level means. The cutoff level means it's just a minimal detectable level. There's no normal level here, and there's no quote-unquote normal level anyway for THC. So the only thing that even the confirmatory test result is telling us is that this person used marijuana at some point in time. We can't say that the level itself correlates to a level of intoxication or extent of marijuana use. I don't know if he's used it once or he's used it 10 times or last week or yesterday. I do not know that. So the question was posed to me, was he high while on the job? And the simple answer was, we don't know based on these lab values. I'd want to know things like, what did his coworkers describe him as in terms of behavior and demeanor, that kind of thing. That's what I'd be more interested in. We have the level to say that he used marijuana at some point in time, but with a level alone, you cannot say with any certainty that he was high on the job when he was injured or not. The second case is this is a 44-year-old man who was stopped for expired registration, and he did not do well on the field sobriety test, so he failed that. Excuse me. And these are the toxicology tests that we have. So his claim was that he used cocaine the day before this failure of the field sobriety test. And so he has the cocaine metabolite, the benzylconazine of 0.3 milligrams per liter, and he has a blood alcohol concentration of 0.05. So he's below the legal limit for the blood alcohol level, and he's saying, I used cocaine the day before. So what does that tell us? What do these lab results tell us? Well, having a cocaine metabolite in the blood does not help reliably determine when this man used cocaine based on just a test result. And there's no indicators documented that tell me he was using a stimulant drug, in terms of like the observations, besides the fact he failed the field sobriety test, and there could be different reasons for that, of course, but, I don't have any data on, how did he appear, what was his demeanor, his physical function, that kind of thing. So it wasn't possible to determine whether the driver was under the influence of a drug, that is cocaine. Maybe the legal limit of alcohol contributed to poor performance, or he was just off that day, or who knows. There could be different reasons for that, but those levels do not tell us that. So let's see if we have any additional questions that came in from our learners today. Everybody asked some great questions so far. All right.
And also, could the attendees type the passcode in once again?
So we had a question come in about a confirmatory GCMS test for cocaine from a urine test reflect what a person's impairment might be. And the answer to that is no. So the confirmatory test is just confirming what we knew from the urine toxicology screen, that there was cocaine on board. And usually they don't do confirmatory testing for cocaine following urine tox screen because there's really no chance of a false positive. But if they did it and they confirmed it with a GC-MS spec, testing and they're sure there's cocaine. No, we can't tie it to the level of impairment. We just know that they used cocaine at some point. All right, this is a question. Somebody's following the news here. I've heard that the drug naloxone can give a false positive for opioids. Is that true? So I mentioned naloxone briefly, and you probably heard about naloxone. The brand name is Narcan in the news. It's the antidote for reversing opioid toxicity. And actually, that's not true. So naloxone does not give a false positive for opioids. And I've had that question before. For example, if somebody is given naloxone by EMS, and then when they get their drug screen, they come up positive. Oh, it was from the naloxone. No, it wasn't from the naloxone. You're not going to get a false positive from that. Let's see. Another question. Do you believe that a toxicologist, as opposed to a medical doctor, is qualified to testify regarding this general or specific causation of an agent based on knowledge of how that substance interacts with the body? So this is a good question, and I'm going to answer it and then take it a step further. So there's different types of toxicologists. So I'm a clinical toxicologist, and that means that I deal more with living patients than with dead patients, although I do have experience with postmortem test results and assay results. But there's also MDs, so I'm a Pharm.D. There's MDs that are toxicologists, and they're typically emergency medicine physicians. So there's certain cases where it would be better to have a physician who is actually familiar with the standard of care and disease states in certain cases. And I'm always transparent about that when I speak to attorneys. I say, you know what, I would like to take your case, but only if I'm 100% comfortable and qualified to do it. And at times I do refer that attorney to a physician colleague because they are better equipped to address disease states as well as standard of care. Can cocaine be passed to a partner through sexual intercourse? That I don't know. I've heard that before, but I'm not sure about that one. I can actually look into that and email the person who asked that question. Let's see. Are there any generally admitted sources that are admissible to relate blood alcohol concentration? I know less than 10 micrograms is the lowest detectable, but do I have to use an expert every time just to convey that into evidence? So there should be an indication on the laboratory report that you would have that would say what the cutoff value is. So that's what you're looking for, to see what the lowest detectable level is, and that's known as the cutoff value. The difference between impairment and under the influence, I don't think I can really answer that question. That sounds like a more like legal jargon to me, and I don't like to even stick my toe into that pond. I mean, I might use that interchangeably, but that sounds like more legal terms. Are there false positives for barbiturates with urine tests? I'm sure there are. I can't think of any off the top of my head, but barbiturates is certainly on a urine tox screen. And with the exception of cocaine, they all have some false positives for sure. So, again, I'm sure that there are, but I can't think of any off the top of my head. After a blood level is taken, will the level change over time? It certainly can. It depends how it's stored, too. So you always want to know, how that's working in terms of change of custody, what's happening to the level and how it's being stored. Okay, this is a question that I've had before in cases. Tell me about impairment with low alcohol levels taken together with a prescription drug like Valium. So Valium is a benzodiazepine, and so the patient can the client can certainly be impaired with a blood alcohol level that's, within legal limits, but then they have a drug like Valium on board that's now intensified the effects of a legal limit of alcohol, causing them to be impaired. So that's definitely problematic. Does marijuana use automatically equal impairment? If someone legally takes it on a medical basis, then drives 30 minutes later, how can impairment be proved if levels of THC are meaningless? Well, we are in Pennsylvania, and in Pennsylvania, and again, I don't stick my toe in the pond of legal terms, but if a person has any detectable amount of marijuana over 1 nanogram per ml, they are considered under the influence of marijuana. And why did they do that? Because this way there's no argument back and forth of you were impaired, you weren't impaired. That level shows impairment, that level doesn't show impairment. Well, I haven't used it for 2 weeks. Then there's no back and forth about that, and that's a problem because there certainly is medical marijuana, but then that is the cutoff in Pennsylvania. Is there an objective method of factoring in tolerance for a drug into the degree of impairment? Wow, that's a very deep question. And the answer is no. There's no objective formula or method or chart or something that you can go to in the literature to factor in tolerance. It's really a subjective thing. I wish there was an objective way to do that. Let me see if there's any other questions. No, I haven't had to do this, so I don't want to ignore this question, but I'm going to say I'm going to have to get back to the person who put this thoughtful question in about comparing vitreous humor alcohol levels, this is postmortem, and blood alcohol levels to try and determine what the different times are retrospectively. But that's a question, Emma, if you can mark that for me to get back, so I'm not sure about that. I haven't been asked that before. Oh, are stimulant levels useful? No. So on all of those slides that I had for the different classes of drugs, there wasn't any of them where it was kind of like a trick question. There'd be like a quiz question, which of the following are drug levels useful for? None of the above. So none of them, the drug levels were useful. They just tell us that the drug was used, provided it's not a false positive, at some point in time, but the drug level itself doesn't tell us a lot. What exactly is confirmatory testing? That's the last question that we have time for, so we'll end with that one. So confirmatory testing is when a method known as gas chromatography, mass spectrometry, GCMS, you'll see it abbreviated, is used. And that results in us being able to confirm the presence of a drug because we are looking at the molecular fingerprint, so to speak, of the drug. So there's not going to be an issue of, oh, is metabolite there? Is it not there? Is there something that's interfering with the assay? So that's what a confirmatory test is. And GC mass spec can be done on urine or can be done on blood. So those are all the questions. Thank you so much for those thoughtful questions. It really showed that the audience was listening and interested, which makes me so happy when there's non-toxicologists that are interested in toxicology. So thank you again for your attention today.
And thank you so much for answering those questions. There are some additional questions, so I will be sending those over to you.
Thank you.
In addition to being your best source for testifying and consulting experts for the past 60 years, TASA also offers e-discovery and forensic solutions, free interactive webinars, cybersecurity services, day-in-the-life videos, and research reports on expert witnesses such as the Challenge History Report 2.0, the Preliminary Screening Report, and the Expert Profile 360. I want to take this opportunity to thank everyone for attending, and most especially Dr. Muller for her time and effort in creating this presentation. If you would like to speak with Dr. Muller, or if you would like to speak with a TASA representative regarding an expert witness for a case that you are working on, please contact TASA at 1-800-523-2319. One of my colleagues will be following up with you regarding your feedback on today's presentation. Thank you very much for attending, and this concludes our program for today.